Hello, my friends. Hello, everyone. This is Rabaa Abdul from the EMRCOG team. Today, we have received the update from the NICE fetal monitoring guideline for the methods of fetal monitoring and the CTG, the 2025 update version. And here it's finally a sharper, clearer, and better version, okay, that will help us to take decision in the most critical moments of the fetal life. So let's go through the update quickly, okay? And I would like to remind you with the approach to the CTG interpretation. And this is will be using the famous mnemonic of the Dr. C. Bravado. I need in every CTG to define the risk. That's very important. So the full risk assessment is going to make a major impact on our decision making. So if the mother have maternal or intrapartum risk factors, such as, for example, presence of sepsis or presence of hemorrhage, or a fetal risk factor, for example, having meconium, or the baby is small for gestational age, or even FGR. This is going to affect our decision and our interpretation of the CTG and decision making for labor. Next will be Dr. C, C for contractions. And the contractions here, I need to assess the frequency of the contractions, right? Whether the contractions are adequate or not adequate. So we will consider the 3 to 4 contractions in 10 minutes as adequate, right? Let them this mean that it's not enough for the progress. More than this, maybe I'm having a hypertonus uterus or attachy systole according to the changes that it is found. Okay, so for example, in this CTG, I will count from this vertical line to this vertical line. This is exactly at 10 minutes because it has 10 squares. Each square of these, as you see, resemble 1 minute on the CTG. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Okay, so this is total period of 10 minutes on the CTG. From this line to this line, how many contractions do I have? I can see that I have 4 contractions in 10 minutes. So that's mean it's okay, right? What's next after assessing the contractions? In the Dr. C. Bravado, I have B, and B for baseline, R for rate. Baseline fetal heart rate is also important, so I would take the baseline in the fetal heart. For example, here, okay, it will be like if I want to draw a line here and take an estimate of the fetal heart rate, I will see that this is maybe 135 up to 140, right? Or 140, yes, between 135 to 140. What else? What else I have here? I have in the assessment of the fetus variability. And a variability, in order to be a normal variability, I would say that this is between 5 beat to beat variability is between 5 to 25, the maximum. Okay, so usually we find it between 5 to 10, but we will consider it in our CTG features is 5 to 25. Very important. What else I'm looking for? I'm looking for what's next after the variability? Yes, well done, the accelerations. And acceleration, if it is present, this is very good, reassuring. But if it's not, then it's not a problem. Now it's time to discuss D. And the D is for decelerations. And the decelerations, my friends, are divided into early deceleration, which is non-harmful, usually, or variable deceleration, And the variable deceleration, as you can see here, is not a relation to the contractions. Variable decelerations can happen as a result of cord compression, or it can also indicate the fetal compromise. So here, the variable deceleration could be associated with concerning characteristic, and concerning characteristic is very important. Any of the following concerning characteristic in a variable decelerations is considered as a worrying sign. So if it lasts more than 60 seconds, or it reduced variability within the deceleration, or there is a failure or slow return to the baseline fetal heart rate, or a loss of previously present shouldering. So this is would be considered as a variable type. And the variable deceleration, as I told you, very big difference between presence of variable deceleration with concerning characteristic, or a variable deceleration without a concerning characteristic. This is one bad feature, presence of concerning characteristics. So one bad feature. For example, here, okay, I can say that this deceleration is prolonged, right? This deceleration is more than 60 seconds. So it has one of the concerning features. What else? There is a failure to return back to the baseline. As you can see here, fetal heart rate, when it going down, and try to recover up, it go down again. And it's same, repeated for few times. Okay, so this baby struggling, right, to return back to the baseline fetal heart rate. If this is feature present also, this is another concerning feature. What else? If there is shouldering, and the shouldering is considered as acceleration, okay, that is associated with the variable deceleration. If it is present and then disappeared, this is another concerning feature. So if there is no shoulder for the deceleration, this is again another concerning feature. Okay, so this is one bad feature in the variable deceleration, presence of concerning characteristic. What is the other problem? The other problem is that I have a variable repetitive deceleration. What is the meaning of a repetitive? A repetitive, my friend, that's mean more than 50% of contraction. What is the meaning of that? I'll tell you. Do you remember when we say here that in 10 minutes, okay, there was 4 contractions, right? So I have 4 here. And look here to the deceleration in the same period, in the same 10 minutes. How many decelerations are there? 1, 2, 3, 4 deceleration. So 4 out of 4, this is 100%. So the decelerations are present within 100% of the contractions. This is again considered as repetitive. Okay, so this is another problem in the deceleration. So presence of repetitive variable deceleration with any concerning characteristic is a worrying feature, right? If this is less than 30 minutes on the CTG graph, I'm still suspicious, okay? But if it turned into 30 minutes or more of repetitive variable deceleration with concerning characteristic, means that I have a pathological CTG. Let's have a look, my friends, here to the CTG, how to interpret it. And this table is very important table that I made for you guys, so you can, categorize the risk of the CTG. And here I have included the 4 features of the CTG: the contractions, the fetal heart rate, variability, and decelerations. And each feature of them, if it is normal, I will give white color. So it's a normal one. If it is non-reassuring feature, it's amber. And if it is abnormal feature, it's red, as you can see here. Okay? So, very important that you know the difference between the feature description and the categorization of the CTG. What is the meaning of that? Contraction is a feature, right? If it is white, I will say I have a normal, right? Contractions. Correct? Okay. What is the comment on the CTG itself? I will say my CTG is normal CTG, correct? Yes. What if the contractions are amber? Amber are non-reassuring contractions. But when I speak about the CTG, I will give the CTG suspicious categorization. I will say this is a suspicious CTG. So when I want to describe a CTG, I need you to know it's either normal CTG or suspicious CTG or abnormal CTG. Please remember the three categorization of the CTG because can be an example. Now, what is normal contraction? What is the contraction in the normal level? Yes, if it is less than 5 contractions in 10 minutes, I'm happy. Okay? What if it is 5 contractions in a 10 minutes or more? This is amper feature. Or, for example, if I have hypertonus contraction that lasted than more 2 minutes, okay? Hyperstimulated uterus, I'm saying this is again amber. And contraction does not have a red feature. And you should know what you will do as a reaction for hyperstimulation. Let's say, for example, the lady who have a hyperstimulation, she is on oxytocin. So remember, right, that what I would do as a result, I can have like some conservative measures, reduce the oxytocin dose or stop it if needed, okay, and continue the CTG and reassess, right? If I'm in need for autocolysis, I would use during labor the terbutaline, correct? So this is for the contractions. How about the fetal heart rate? Fetal heart rate normally between 110 to 160. When to worry about the fetal heart rate as a non-reassuring? If there is increase in the baseline fetal heart rate of 20 minutes or 20 beats, per minute or more from the start of labor or since the last review an hour ago. Why this is a non-reassuring? I'll tell you. Look, my friends, let's say a patient presented to me with baseline fetal heart rate 115. Is that normal? Yes, normal. Well done. After sometime in labor, I found that it's 140. This increase in the baseline fetal heart rate could be early sign of deterioration. Okay? And this baby is going to develop a tachycardia afterwards. So be careful, right? This could be early signs of deceleration, the change in the fetal heart rate, even if it is still within the normal, but it's 20 beats or more, okay, in a minute since the start of labor or since the last review 1 hour ago. This is considered as amber feature. This is non-reassuring feature. Or when I have baseline become 110 to 109, or if there is inability actually to determine the baseline in the CTG. So if I'm not able to determine the baseline, this is another amber feature in the fetal heart rate. When to say that the fetal heart rate is abnormal, and that's mean I have a red feature, that's mean I have a pathological CTG. It become red if it is slow, okay, less than what? less than 100, I will say it's red, less than 100 beat a minute, or it is above 160. So in the exams, they can play smart, but not smarter than you. They can play smart and tell you that it's 160 exactly. Is 160 a problem? No, no, not at all. Now, time to discuss the variability. So, variability, which is the beat to beat variability, or it reflects actually the beat to beat fluctuations in the fetal heart rate due to the interplay between the sympathetic and parasympathetic nervous system. It's one of the most important indicators of fetal well-being. A normal variability range between 5 to 25 beats a minute. And if it is less than 5 minutes, this would be called a reduced variability. So it will be like this. I will show you later on a picture of the CTG, okay, with reduced variability. So if this reduced variability is prolonged and it between 30 minutes and 50 minutes, this is something that considered as non-reassuring feature, and it's given the amber color, and if it continued more than 50 minutes, it would be considered as a pathological feature on the CTG. So reduce the variability less than 5 minutes. If it is for a short period, that's okay, because can actually indicate just the fetal sleeping pattern, right? And if returned back to the normal between 5 to 25, this means that the baby is well oxygenated and the autonomic nervous system is normal and intact, and there is good fetal reserve actually during labor with low risk of hypoxia or acidosis. So a normal variability is something reassuring. But reduced variability, as I told you, it could, if it is for short period, less than 30 minutes, this can represent a fetal sleeping cycle, which is something completely normal. So that's why we are not concerned if it is up to 30 minutes. But once it's between 30 to 50 minutes, I will be a little bit concerned here, right? Because can be seen in some situations like prematurity, which is okay, or mother is taking opioid or magnesium sulfate in labor. But the most dangerous thing is that can be early signs of hypoxia, right? Or evolving a metabolic acidosis. So it's a concerning, right? And I need to follow up and see. If this variability lasts more than 50 minutes as reduced, I will be so much worried because this is highly pathological and it associated with significant fetal hypoxia or acidosis or brain injury. Okay, so however, in the same time, increased variability more than 25 is not something that we like. If it is for 10 minutes, for up to 10 minutes, I'm still worried. Why? Because can also represent that the baby is at stress, fetal distress, okay? And I will give it as amber features. Sometimes it can happen with core decompression, or it can be in a mild or early hypoxia. If it is persistent, increased variability, this actually means ongoing fetal distress and you need to escalate to a senior obstetrician immediately. Okay, so this is for the variability. How about decelerations? And decelerations, my friend, this is the most important feature, and this is the most common feature that people find it challenging or can have mistakes in it. The deceleration, if it is nothing, no decelerations at all, I'm happy. White. Early deceleration, which is called the mirror type deceleration, or in response to fetal head compression, it's fine. Okay? And variable deceleration with no concerning characteristic, also it's okay. Once concerning characteristic appeared, I'm now non-reassured. I'm now amber in the color. Variable deceleration with any concerning characteristic for more than 30 minutes is something amber. But if it is repetitive as well as concerning characteristic present, so this is double risk factor, that's mean less than 30 minutes I am suspicious, but if it is 30 minutes or more, it will go to the red and the CTG become now a pathological CTG. So please be careful with the variable deceleration. Variable deceleration with the presence of concerning characteristic is something that is worrying, right? And if it is concerning and repetitive, I'm even more worried. This should not last for 30 minutes. If so, it will be amber, but once past the 30 minutes, I'm now in the red zone, okay? And once I am in a red zone means I am in dangerous to the fetal hypoxia, right? And fetal distress. Presence of late deceleration, and this is the new thing because the previous version we used to have late version two types, okay, of the categorization of late decelerations according to the period, but now they have actually mentioned in the 2025 update that the presence of late deceleration, this is actually means the placental insufficiency, the placental inability to deliver oxygen to the baby. That's mean fetal hypoxia. That's mean red feature. That's mean a pathological CTG. And means also that you need to take fast decision in regard to the labor continuation. How about acute bradycardia? Acute bradycardia or a single prolonged deceleration lasting 30 minutes or more is of course as a red feature. And a red feature means that I have a pathological CTG. Now, my friends, you need this table, okay, for your study, right? And for decision making regarding the CTG. In exam, he can describe to you the CTG in words and ask you to choose the categorization, correct categorization, or correct action. Or they can give you different CTG, pictures for a CTG, okay, and ask you what is the management, as I told you, right, based on the interpretation of the CTG. Don't forget, please, that interpretation of the CTG is never, ever away from the whole clinical picture. You need a full assessment. And the first thing in the Dr. C. Bravado mnemonic was define risk. And I'll show you here, my friends, action based on categorization. Put in mind the full risk assessment, please. So it's a normal when everything is normal, when all features are white, right? So I will say this is a normal CTG, and I mean that continue observation of labor, no problem. I would say this is a suspicious CTG if I have only one feature amber, or I would say this is a pathological CTG if there is two amber feature or one red feature. So let's see what I will do. What's my response, okay, to the CTG after categorization? My response is as follows. If is it normal, what to do? If it's normal, I will continue the CTG. Unless it was started because concern arising from intermittent auscultation, I will go back to intermittent auscultation. But otherwise, if there is an indication to continue CTG as such, and continue to perform for risk assessment at least every 1 hour and document the finding. Okay? How about if the CTG is suspicious, but suspicious without other concerning risk factors. And remember, the risk factor, okay, is considered as maternal or a fetal risk factor. So if I have a suspicious CTG, what to do? If I have a suspicious CTG, what I would do is full risk assessment, full set of maternal observations, and taking into account the whole clinical picture, document the findings. Note that if accelerations are present, the fetal acidosis is unlikely. If the CTG trace was previously normal, consider possible underlying reasons for the change. Undertake conservative measures as indicated. If the CTG trace is categorized as suspicious, but there is additional intrapartum risk factors, such as, please count with me, slow progress, sepsis, or presence of meconium, and this is just an examples. Okay, other risk factor like bleeding, for example, or blood stained or red stained meconium, for example. Okay, this would be another risk factor, of course, to be considered, plus the suspicious CTG. What if I have this suspicious and additional intrapartum risk factor? Again, for risk assessment, maternal observations, consider possible underlying causes, and undertake conservative measures as indicated. Conservative measures, my friends, are very important to remember that I don't need to start oxygen routinely as conservative measures. I don't need to start IV fluids routinely as a conservative measures. It should be an indicated only when indicated or when needed. For example, low saturation in cases of sepsis, for example, I give oxygen. Otherwise, giving oxygen with a normal saturation will be harmful, doing harm more than good. If I have a case with hypotension, I would give IV fluid, or otherwise, if I give IV fluid, I am having overload, right, to the maternal circulation. Avoid it, please. So here, what is the actions after the conservative measures? Actions after conservative measures could be either fetal scalp stimulation and record if there is response of acceleration to the fetal heart rate after digital stimulation to the fetal scalp, or expediting birth according to the situation. So I can take decision to go to birth or expedite the birth based on a suspicious CTG in case of additional intrapartum risk factor, right, after applying conservative measures. What if? What if I have a pathological CTG? Pathological CTG, that's mean I need urgent review by obstetrician and a senior midwife. I need to exclude acute event. For example, cord prolapse, suspected placental abruption, or suspected rupture in the uterus that need immediate intervention. Otherwise, perform a risk assessment, take maternal observation, and consider possible underlying causes. Undertake conservative measures as indicated. Again, conservative measures have a role here, and it could be, for example, changing maternal position, or if there is excessive contraction frequency, stop or reduce the oxytocin according to the need, and consider terbutaline if there is need for a tocolytic afterwards. Don't give oxygen routinely, don't give IV fluid routinely. Then again, my friend, if it's still pathological, what to do? Please evaluate the whole clinical picture and consider expediting birth. And this will be according to the stage of labor and the vaginal finding, either to go for instrumental delivery in case if the safety of the instrumental delivery is fulfilled, or going for a cesarean section. What about if I have acute event or acute bradycardia or a single prolonged deceleration for 30 minutes? Again, urgent obstetric review, exclude acute events, consider expediting birth. While you are preparing for birth, conservative measures as indicated. Remember that I would expedite birth if acute bradycardia persists for 9 minutes or less if there are significant antenatal or intrapartum risk factor or fetal compromise. If the fetal heart rate recovers to at any time up to 9 minutes, I would again reassess any decision to expedite the birth, but take into account other antenatal and interpartum risk factors and discuss this with the woman. If a decision is made to expedite birth, ensure the time at which urgent review was thought and the time the decision was made are documented. My friends, I hope that today I've cleared to you some of the concepts regarding the CTG. Of course, you need practice and application of these principles and this table for a CTG cases. You can start from your workplace and your cases that you see in daily life and in the labor world and participate in decision making using the latest update of the NICE guideline. Thank you very much, my friends, and see you in another episode of the EMR COG online sessions.